7, 6, 5, 4, 3, 2, 1.
Hi, everybody, and welcome to our Hair Talks for September. We are thrilled to welcome everybody to this webinar. This has been a wonderful series that has been put together by Global Cosmetic Surgery. Fascinating group that really started and then COVID hit and pivoted to these virtual webinars where we get people from all over the globe to attend and learn. Just incredible amount of knowledge that we've all shared over the past 4 or 5 years, and thrilled to be hosting these sessions on what we call Hair Talks. I want to thank Dr. Deborah Shomei and Tanuj Nakra, who are the heads of Global Cosmetic Surgery. We're going to hear from Tanuj in a few seconds. But we have a great group today, and this one today is sort of set up to learn about female pattern alopecia, and it's tailored for all kinds, all healthcare professionals, dermatologists, endocrinologists, gynecologists, diabetologists, and we're going to expand our understanding of female pattern alopecia and its interconnectedness with broader health issues. So we're going to take a comprehensive insight into the pathophysiology. We're going to take advanced diagnostic approaches, some holistic treatment protocols, and collaborative patient management when needed, and how do we enhance our patient outcomes. That's the key for all of this today. And we will introduce the panel and our guest speaker in a few seconds. But for now, I'd like to have a video played of one of the founders of this, Tanuj Nakra, who's a plastic surgeon in, I think he's in Austin, Texas. And he's going to give us a little intro into global cosmetic surgery. So team, we're ready for your video. There we go.
Excited to kick off another episode of Hair Talks, which is a part of the programming of Global Cosmetic Surgery. My name is Tanuj Nakra. I'm an oculofacial plastic surgeon in Austin, Texas, in the United States, and I'm one of the co-founders of Global Cosmetic Surgery, along with my partner, Deborah Shomei. We welcome you all to be with us today. Today, we're excited to have an episode of Hair Talks where Dr. Glynis Ablon from Manhattan Beach, California, is our keynote speaker. I'm particularly excited to hear what she has to say. She is a world-renowned speaker, scientist, educator, and also she's on clinical faculty at UCLA, where I trained. So we share that in common. And Dr. Ablon, I think you also trained in Texas. So you have had some heels on the ground here, pretty close to where I am. Also wanted to thank Dr. Michael Gold, who is our chief mentor and moderator for Hair Talks. Dr. Gold doesn't really need an introduction to most of the audience here, but he's in Nashville, Tennessee. He's in charge of so many organizations, it's hard to keep track, but he really has worldwide recognition for his cutting edge research and contributions to the technology of aesthetics and dermatology. And as always, Dr. Gold, we thank you for being a part of our organization and helping to lead another session of Hair Talks. So I'll speak for just a moment about Global Cosmetic Surgery. We have been an organization that has been bringing free programming to the world since the pandemic. We were inspired by a lot of the efforts that occurred internationally during the pandemic, when we were all unable to be in our clinics and unable to go to conferences, Global Cosmetic Surgery was born. And the momentum we created in the organization has been wonderful. And we've been pleased to put out dozens of educational events. We now have 2 regular series of events. HairTalks is one of them. We also have Aesthetic Talks, and Aesthetic Talks focuses on aesthetic surgery and both surgical and non-surgical treatments. We'll have another episode of Aesthetic Talks coming in November. Please follow us on social media and stay tuned. And we'll be excited to welcome you back for that session in the future. I also want to take a moment to thank many of our panelists that have joined us internationally. Dr. Lenizzi, Dr. Santhanam, Dr. Shivaram, Dr. Kandari, Dr. Saoji, and Dr. Shenoy. We are grateful for your time and efforts and look forward to having you join us in the session to lead the discussion later on. At this point, I'm going to hand it over to Dr. Michael Gold, who will take the reins and introduce the session, and also to Dr. Ablon. Thank you once again. Thanks for joining us today.
All right, thanks, Tanuj, and that's great. And so, yeah, Global Cosmetic Surgery has been an amazing organization. I've been part of many of their webinars, and I encourage you, if you have not, to get on them and actually listen to these incredible global speakers. I think one of the things that I love the most is we have people from all over the world here, and we get to share knowledge and collaborate. You may do something in your country that we don't do here, or vice versa. And that's how we learn the best, right? How do we incorporate things into our practices? How do we do best practices from learning from our colleagues from all over the globe? And I know that I have learned some amazing techniques over the years from this group. Today, as Tanuj said, we have a wonderful panel made up of dermatologists, endocrinologists, gynecologists, and we have ways that we can we all collaborate and do things like that. I do want to make one more comment before I turn the microphone over. If I can only find it, it's just hard. I have 8,000 texts from these people. But there is we want you to ask questions and send the questions through, and I'll find what I'm looking for after we do what we're looking. But I don't want to waste any time. So I want to introduce my good friend, Dr. Glynis Ablon, who, as Tanuj said, is a board certified dermatologist based in Manhattan Beach, which is in Los Angeles, clinical associate professor at UCLA, and really one of the world's great researchers in lots of different things, but hair has been a specialty of hers for a long time. And I know we're going to get a lot of good information on female pattern alopecia, why, when, and how do we treat. So without further ado, I'm going to turn it over to Glynis. Thank you again for being here early in California, and welcome to Global Cosmetic Surgery.
Thank you again, Michael, for having me. So I'm going to go ahead and share my screen with you guys, and we'll get started here. Let me start by saying that I am a person who I had beautiful long ringlet hair, and my mother decided to chop it all off at the age of 3 and into a pixie, and I wouldn't let her comb it through with a fine-tooth comb. And I had then a perm for 15 years, and I finally got to a place where I felt like my hair was okay. And then I'm going through menopause. So I have kind of gone a little bit of the journey my patients are going through. I also had started my research in hair around 15 years ago. So it is something of a passion of mine. And I think that everyone should understand it and realize now that we really do have a lot of treatment options that are available to us. So these are my disclosures. Again, I do a lot of research in hair, and we have some new ones coming up as well, but here's some of what I'm doing right now. So why do we discuss it? I think it's really important to understand that hair loss really is the second largest segment of aesthetic procedures in the US. So for us in the US, this is something that when you realize you can discuss it, almost every one of my patients wants to have a discussion about it. They could come in for a body check, they could be coming in for something completely different, and all of a sudden they say, well, I heard that you can treat hair loss. Is that true? So it is something that we go into. There's about 80 million Americans right now that are suffering from it, and over 30 million are female. So we need to remember that women deal with this as much as men, and oftentimes a man may just shave his head and it's not a big deal and that they're comfortable with that, but most women are not comfortable shaving their heads. They don't want to if they don't have to, and they oftentimes will end up wearing a wig if that's the case. This is a great article. It's actually a study, and I really like to show it because it's back in 2011, so 13 years ago. They evaluated 2,000 women, and what was most amazing to me is I know hair loss can be an issue, but I thought 79% said they were less happy if their hair didn't look right or if it wasn't looking nice. Some were depressed. And I think a lot of people would be shocked again that 66% that were suffering from it, again, were thinking about their hair all the time. And almost 40% said it actually affected their sex life. So these were numbers that I was surprised at. But then when you have the conversations with your patients, you are not surprised. People do really get upset when they're dealing with hair loss. So I want to start off just a little bit with the etiology of hair loss. We are now understanding that there really is this multifactorial etiology. It's not just, it's genetics. If you have it, you don't. That's the answer. You really do need to look through this list. Again, talking about genetics, listening to a family history, but also looking at hormones and where people are in their cycle. Are they perimenopausal? Are they menopausal? Where are they in that healthcare journey? How is their health and nutrition? And I love to have talks about nutrition because I always say you are what you eat. We know that there is a gut, skin, brain connection. And so the better things you put in your body, obviously, the better your body will respond. And so I actually give handouts on nutrition and hair loss, specifically things that can help with hair loss itself. I also like to really detail the lifestyle people live. What kind of products are they using? How much are they drinking? How much smoking? How much exercise are they getting? Because again, multifactorial. So the better lifestyle you have, the better your hair will respond. And then stress is a big deal. I went through a very stressful period where I woke up paralyzed about 10 years ago when my mother was in the hospital. And stress can do bad things, not just on your hair, not just that inflammatory response on the follicle, but on every part of your body. And we have many people that come in just with a rash and it's stress induced. So addressing the stress of every one of my patients is a very big factor that I approach. Environmental is another one. And in some cases, we don't have a lot of control. And in some cases, we do. So for people that can maybe get out of LA or get out to the beach and get a little bit further away from the pollution and protect their hair from the ultraviolet radiation, that will help as well. And now we have this knowledge of what's called inflammaging, which is a term that was coined by an Italian dermatologist. That is really this chronic inflammation, these free radicals, oxidative stress around the follicle, and throw that follicle out of balance. And I also have tried to do some references at the bottom of most of my slides so you can look up some of this information. Again, this excess inflammation leads to this formation of the free radicals. You're getting the cytokines, and again, you're disrupting that normal cell cycle and tipping the scale toward the regression of the hair follicle. And I throw this in here because please have the conversation about stress. Find out what people are doing, how much stress they have in their lives, and address it. I will talk about stress reducing techniques all the time. I talk about meditation. I talk about yoga. I talk about biofeedback, about float tanks. I think it's really important, again, to understand that stress does inhibit hair growth. We know that you're going to get that mast cell degranulation. You'll get the pro-inflammatory cytokines, reactive oxygen species. And again, you're going to get that cortisol release in the follicles, and it's a big deal. And you can lead to that apoptosis or the hair follicle regression just from stress alone. So I wanted to go through my consultation, kind of the steps that I take. I think is very useful of how I will approach a patient that comes in with hair loss. And these are the little steps that I take. So number one, I do have a detailed talk with my patient. You really want to get questions answered. I do have handouts. I'm a big paper person, so I have patients fill out a handout while they're in the waiting room or while they're waiting to see me so that I can kind of go over that handout with them when we're discussing it. And this is basically what my handout talks about, what their lifestyle is like, What's their nutrition like? Are they eating organic? Are they craving a lot of sugar? Because again, we know that that bad gut bacteria is what promotes people to continue that bad behavior in what they're putting in their body. So are they getting enough protein, and are they a vegetarian? What are they doing in their lives that might also be affecting their hair loss? And as I said, stress and stress level and stress management is key. And that can also be applied to their work life, their family life. Do they have family, elderly people that they're taking care of, or babies that they're taking care of? Again, discussing all of that. I like to talk about the toxicity. So amalgam fillings, are they doing a lot of sushi? What kind of pollution are they living in? Where do they live exactly? And then I do try to talk about avoiding plastic containers if possible, and especially the BPOs. Sleep schedule. I think we realize more and more now that how well you sleep affects everything that goes on, from your hair growth to your any kind of inflammatory diseases or autoimmune diseases or IBD, basically anything. So if you get a good night's sleep, and as I said, it's quite early here in California right now, but if you get a good night's sleep, so I went to bed early at 9 o'clock so that I knew I would get my good at least 8 hours. Look at the patient's sleep schedule. Are they getting a good night's sleep? Are they waking in the middle of the night? Are they having difficulty falling asleep? And you can get that cortisol dysregulation or adrenal fatigue, which can be associated with the chronic stress. Discuss the hot flashes, night sweats as they're in menopausal transition. All of these things are something you want to address when someone's dealing with hair loss, but in their general lives as well. I go through menses, pregnancies, and menopause, discuss any kind of medications listed here, past medical histories, family history of hair loss, because you do want to get that genetic component at least. And then we talk about hair care products. I really want to know what they're putting in their hair. Are they staying away from different kinds of sulfates and phthalates that we know can affect your health overall? How often are they washing their hair? Because we know that the more frequent washing that you do, the more damage it can be to the hair. Are they drying their hair on a low dry or a high dry? The high dry, of course, will damage the hair as well. And then does a patient wear, how they're wearing their hair? Are they wearing these tight braids? Because we know that can also contribute to hair loss in a different kind of fashion. Step 2, this is where, again, we're talking about basically female pattern hair loss, but it's critical when a patient comes in, because someone may come in thinking that they have female pattern hair loss, and it may not be. So I think it really is critical to make sure you're diagnosing the right patient. What does the patient have? If I have a patient that comes in, thinks they have a female pattern hair loss, but they have a frontal fibrosing alopecia, my treatment will be very different. And so I think it's important to know what you're treating. And if you're not sure, do a biopsy. That's always what I tell my residents. If you're not sure, take some pathology there. But I do check in a physical exam. I'm looking at the hair itself. I'm really trying to see, is the hair breaking, or is it actually coming out at the roots? Is it thinning, or an overall increase in shedding? Is there patchy hair loss? What's the texture? How long does their hair grow? They may come in and say, my hair is usually down to my waist, and now it won't grow past my ears. The pattern, the distribution of the hair loss, is there hair loss in other areas? Is there any acne or virilization? And then I'll whip out my dermatoscope. I have lots of different tools in my armamentarium, but I really always like to use my dermatoscope, and I want to look for any kind of inflammation, erythema, scale. Do I have an active ostia, or is it absent or scarring? And is there any kind of symptomatic pain or burning? My next step is procedures and lab work. And I always get some labs, because we know just right off the bat, thyroid disease, which is very common as we get wiser in our years, is a part of hair loss, or can be contributing to hair loss. So I'm always getting thyroid. I'm getting typically ferritin and CBC. I like to get vitamin D and zinc, because people are often deficient. And then the other list here are things that I will add on or not use based on the life cycle and where the patient is in their menses and things like that. And then I also like to do hair pull tests. As I said, biopsies are critical. If you're not sure, get 2 punch biopsies, 4 millimeters, cut vertical and transverse. That's what my pathologist likes to see. And especially if you're dealing with a scarring alopecia. I might whip out my Trichoscan. I always do micro and macro photography, and I might even do a hair mount again, depending on what is going on with the patient. The 4th step really is the treatment options. And so once I have a diagnosis established, and I may or may not be at the point where I want to give them a diagnosis on that first day, probably 50% of the time I will. And I really need to, again, treat the cause. So what am I dealing with? I need that diagnosis so I can be able to tell the patient the best treatment options that we have. And I will then once I've diagnosed them, again, treat the cause. You know, if you've got an abnormality in the labs, you need to treat that first. It doesn't matter how many treatments you're doing. If they've got thyroid disease and you have not addressed it, you may be adding all these different kinds of treatments on and the patient is not responding. So do that first. And then this is kind of a list of different things, not just for for the androgenic alopecia, but in general alopecia. So typically supplements are great for any kind of alopecia, and I'll show some pictures a little bit later, but supplements, again, if you had the perfect nutrition, and what we have, at least in the United States, is what's called the SAD diet. And I always say you live up to your name. So we have a pretty sad diet. So people are oftentimes missing things they need in the diet naturally to help with hair growth. So that's where supplements, I think, are really key, because we're not getting what we need. And if you had a perfect diet, you might be able to avoid it. But here in the United States, we do not. So I think it's really something to keep in mind for everybody. And then I will talk about topical agents. There's prescription strength ones, over-the-counter ones. I may add it with microneedling. I always talk about LED and lasers. Sometimes I'll just do some cortisone injections. I might do some exosomes. Again, you can do intradermal minoxidil, you can do PRP. I talk about prescription strength prescriptions that I can write for my patients. I also talk about, again, tacrolimus, which is immune modulator, really depending on the type of hair loss in that situation. The JAK inhibitors, methotrexate, oral medications, again, depending on the diagnosis. I may do experimental productions, injections with proteins like copper. There's some newer things out there. I think you're going to hear about that today as well. Always talking nutrition and stress management. And of course, if we get through all these treatments and we've done all these treatment options, or a patient says that's not what I want to go through, transplant is certainly an option depending on what their hair loss looks like. Very important that you have a conversation when you're going through the treatment list of, you know, what are we talking about for price? How often do they have to come and see you? Remember, with androgenic alopecia or female pattern hair loss, treatment is forever. So I have to make sure that my patients understand, if I give them something and it's working, they're going to stay on that for the rest of their lives. So really make sure your patients understand what they're getting into and that they're willing to commit. So a bunch of references down here for you to look at. So last little bit on, again, treatment options. I talk about just the hair aging. So I like to protect the hair, so that I'll talk about different kinds of skin conditioners that you can use for the scalp. Cuticle coating, I'll talk about sun protection for the hair, which can include just prevention with hats, but also there are sunscreens that can be sprayed onto the scalp. I like to keep the moisture in, so again, avoiding harsh shampoos, frequent washings, chemicals, which of course, for those of us who color their hair, when they say just color it once or twice a year, probably not an option, but again, low heat on the blow dryer. And then I really do try to say reducing the environmental stressors and inflammation. And that can include going to a low glycemic diet, reducing their stress in their lives, and helping with their environmental stress as well. So once I've established what I'm going to do for a specific patient, then I will have a follow-up. That follow-up is typically happening at about 3 to 6 months post-treatment. And it really depends on what treatment options we've chosen. Some treatments, you'll be seeing that patient every single month, but if they've committed to, let's say, a topical or a laser that they're going to use at home with their topicals, with their supplements, I do give it at least 3 full months, and I will have performed pre-treatments with hair matrix as well, because that will allow me to actually count hair follicles, tell me how many vellus, how many terminal hairs I have, the ratios and the density of the hair, and then I will repeat those photography sessions at that 3-month mark. I don't typically see the patients and have the pictures taken again at a one-month mark, but you can look using your dermatoscope, trichoscan, and see that there are new hair growth in the area that you've been treating. So again, wait 3 to 6 months, make sure you take baseline pictures. In everything we do in aesthetic medicine and dermatology, at least, we take pictures on everything. And I say, if you're not sure, take a picture. So that's really important. And then going over the treatment regimen, discussing again at that follow-up appointment, you know, how the patient feels. Oftentimes these patients are very careful and they really look at how their hair is responding. So they may be keeping baggies of hair and notice that there's less hair in the baggies that they've been collecting for you, but really talking with the patients on what they're noticing. Are they seeing more hair loss? Are they having more shedding or more in, you know, hair on the pillow, things like that? Is it changing at all? And then going back over, has their sleep schedule improved? Has their stress improved? Has their nutrition or diet improved? Any new toxicities? And then I consider maybe any other tests that need to be either rerun, recheck. Perhaps it's a thyroid that they've been taken care of, and we want to make sure that it's actually better. So that's, again, something that we go through. And then we determine the next plan of action. Are we adding something into our regimen? Are we replacing something? And again, what is the patient compliance? And it's kind of like when you deal with kids and acne, is that if you talk to the parents and the kids there and the parent says, I want them to be on a medication, I will always say to the teenager, are you going to use it? And if they look at me and say, no way, I mean, you're kind of wasting your time. So you really want to make sure that the patients are on board with whatever you're going to do. So now let's go ahead and get in depth into the treatment options that we have. There are new technologies that are being studied, but I'm going to go through the majority of main items that are available to us, certainly in the US. This was an article that I published with Dr. Nestor and his team, basically talking about what our options were a couple years ago back for androgenic alopecia, really understanding the risks and benefits. And again, these are things you need to share with your patients. Patients need to understand, how successful these treatments are, how much are they going to cost them, and how often do they need to use them? Is there good efficacy, good data? Do they have a lot of side effects with them? How easy is it to comply and use this regularly? And then what is the cost? And again, remembering it's a lifetime commitment. So as physicians, I think our ethics are to explain all of these things to our patients and make sure that they realize what they're getting into. So I'm going to start off with the medical treatments we have available, and these are oral medications that we can get as prescriptions in the US. And again, finasteride and oral minoxidil have been around for a while. You can see that the evidence is strong for the finasteride. Efficacy is excellent. There are some side effects, and again, orthostatic hypotension, patients can have some dizziness, but erectile dysfunction and decreased libido really are the highest concern when we talk about putting on someone on oral finasteride. And I try to explain to my patients that the percentage of that is low, but oftentimes, even if I say to a male patient that it's low, they still don't want to go on it because of the side effects. But in women, if they are old enough, and typically I won't prescribe this unless the woman is of past childbearing age, if they're at that point and they're willing to do the side effects, then we can, of course, prescribe that for women. And again, it's easy to take. It does inhibit the conversion of testosterone to the dihydrotestosterone, which is that hair miniaturization. We don't really have any data that really shows it works for frontal hair loss. And again, these women have to be past the age of childbearing. And we start off usually with that 1 milligram a day. The minoxidil has moderate evidence, the good efficacy, but from all the data that I've seen, there isn't a lot of difference between the oral and the topical version. They seem to work just as well with the 5% topical. The issue becomes that there's a big hype now doing oral medication. Some people feel it's a lot easier. And again, that's where you have to discuss with the patient what their lifestyle is like. Can they put this topical on? Some of the newer formulations are a little bit more pleasant. It's important to explain how to do it, really parting the hair, not just spraying it all over, then it gets in the hair and people are unhappy. So really explaining to a patient how to use it. Understand that there are some side effects. They can have an increased heart rate, low BP, can get some weight gain. The biggest side effect that we see, of course, is the hypertrichosis. So you have to start at a very, very, very low dose. And you can see at the bottom there, we start off at that 0.625. We go up if we need to based on the patient's response. But again, affordable and easy to prescribe if the patients are willing to do it. It is just taking a small pill. You can do medical treatments that are compounded. So you can, again, use that topical minoxidil that you can get over the counter. We have a pharmacy that basically formulates one that is a combination of the finasteride with the minoxidil with a retinoic acid that allows better penetration. We can also get it compounded with dutasteride, which is 3 times stronger than finasteride. So it also can be compounded and given to the patients. We don't have a lot of data. That's the problem. There isn't a lot of data on it. The evidence is weak, but the efficacy seems to be good. And my patients seem to be very happy with that combination. Compliance is high. It can be affordable from these pharmacies, but again, not with women of childbearing age. So that's really important to understand. Other hormonal therapies, you've got spironolactone. That became another big buzzword, and a lot of people were writing it. The evidence is really weak on how it works in androgenic alopecia, but the efficacy seems to be good. I will tell you, it's not one of my first lines. I don't think it works great in my patients, but it's something that can be added on to a treatment regimen. Side effects are really rare. The biggest thing we see is irregular menses if the patient is menstruating, and increased urination because it is a diuretic. Compliance is high. It's an easy pill, very affordable, but again, not for anyone with kidney disease or pregnant women, of course, and seems to work best in female pattern hair loss for those who do use it. Doses are at the bottom, usually 100 to 200. Most people start off at about 100 milligrams a day. And again, it does decrease the testosterone production in the adrenal glands. The flutamide and bicalutamide, weak evidence, but efficacy is good. We do have side effects with liver toxicities, hot flashes, and again, things you want to keep in mind. GI complaints can be an issue. Really, the compliance seems to be better for the bicalutamide than for the flutamide. It is affordable, but it can interact with other medications. So make sure that you get the warning out there, explain to the patient there can be hepatic failure. That oftentimes may be something where someone says, I don't even want to try it because of that, but it is an anti-androgen, and the dosing is 250 milligrams a day. So complementary alternative medicine, in the United States, about 30% of individuals really do want complementary and alternative medicine. They really like the idea of not taking a drug, something else they can do that doesn't go internally in their body. So we have a couple different options here. Low-level lasers, the data is really strong for this. Efficacy is excellent. And low-level laser therapy, I think, is really something that's been underutilized in all of dermatology. We see that it can work in a lot of other fields, but the side effects really are zero, and there's no pain involved because, again, low-level lasers have a very low energy that's put out, so they're not having any kind of heat, so there is no pain, no sensitivity whatsoever. But it can be expensive, and I tell my patients that are doing low-level lasers that I really like to have them on it for 6 months before I do some photography to see how it's working. But we do get great results with it, and we do have this biostimulation effect. Hypothesis, this mechanism is still really unknown, but these are some suggestions of what happens. Light-emitting diodes is one of my favorite ones to give patients to take home. They can get it on the internet. We do sell it out of our office because it's just an easy device. It's a cap, and you can see on the picture at the top, that's actually my mom before she passed away. She loved coming into the office for her laser for hair growth. Of course, she was 88 years old and noticed her hair was a little bit more thin, and she just loved getting her laser done. But the light emitting diodes, again, the efficacy is good. The only real side effect is if your home unit doesn't function right or if there's some problem, but the company's really great about replacing. Compliance is moderate because, again, you do have to wear it every day. It is affordable. And again, similar to the low-level laser, we are seeing that it does promote blood flow. It is non-coherent, and these are about 10 minutes a day. It also has been just recently, they showed that it does actually reduce the DHT production, so it's really a nice option. Just a picture to show you of 6 months use of LED therapy. In that same venue of the complementary and alternative therapy, we've got the platelet-rich plasma. I put microneedling on here. Platelet-rich plasma is great. We use it for a lot of different things, not just hair growth. The evidence is strong. When we did that review, really the low-level lasers and the PRP really were the top two that worked the best in the diagnostic and treatment for patients with frontal androgenic alopecia or female pattern hair loss. Efficacy was excellent. We really saw very little side effects. Sometimes people can have a little bit of a burning sensation. It can be a little uncomfortable. Depends on how you deliver the PRP. Sometimes we'll do little ring blocks. Sometimes you can actually deliver it with microneedling. It just depends on your case. And again, patients do well. Younger women do really well. We do frequent injection. It's usually once a month for a session of 3 to 4 months. And then we will wait 3 months and have the patients come back, and we will do pictures again to see how much hair growth we have. Remember that once you prepare the PRP, you really do want to get it injected or put into the scalp within an hour. And again, you've got this enhanced proliferation, differentiation, and angiogenesis of the dermal papillae and the stem cells in the bulge. Microneedling had weak to moderate evidence with decent efficacy. Again, pain and bruising and folliculitis were the common side effects with it. Compliance was good. Cost can be expensive. It just depends on where you get it done. But we don't really have any good standardized protocols. My best treatment with microneedling is to add a product. So whether that's PRP or growth factors or exosomes, I do like to add something in when I'm doing a microneedling session. Just a picture to show you of my patient after 4 sessions of PRP. You can see that density has improved, the thickness, everything. And this is a patient that comes and sees me now, usually once every 3 to 4 months, and just is really thrilled with her progress. Some other ones that are kind of newer, linatoprost has had some weak evidence, but it has good efficacy, rare side effects. The compliance has been high with it. It's only been tried really in a mild androgenic alopecia, so I think more data needs to be done. The bone marrow mesenchymal stem cells is something, these are regulated donor banks. It's got growth factors and cytokines, and we get good results with this. Again, typically I like I love the idea of doing something in the office and then having a patient follow through at home where they have some kind of product that they can use at home. So this is something where we will do the procedure in the office and then we will send them home with their home hair kits. When you're dealing with these cultured media, I think we're knowing now that these cultured media not only have the products that are released, they're also having exosomes. So we're getting our exosomes even in that way when we're using these cultured media in the scalp. Just to show you the Wnt pathway, I think this is important that we have to understand that this is a pathway that does help with hair regeneration. And basically these conditioned media cells are activating the dermal papillae. And you can see this is a before and after of a patient having this done for 3 months. Supplements is another big category. And as I said, if you have a perfect diet, perfect nutrition, you may not need it. But everyone out here, at least in LA or in the United States, I think really don't. So these are the two of the ones that we've studied in our office. The nutraceutical supplemented with the standardized botanical extracts that had weak evidence, but good efficacy. And our studies in the office have had phenomenal results. We have different ones. We did the first study that was for menopausal and perimenopausal women using this, the supplement specifically for that from this company. And our results were phenomenal. We had not only happy patients with new hair growth, but we also had the symptoms of menopause improving with that as well. Compliance can be high, which is nice. They're moderately affordable. And again, clear to understand that patients have to stay on these medications. One question I always get when it comes to this specific version is it's 4 pills a day. And people oftentimes don't like to do that. I take mine 2 in the morning, 2 at night. But you can put them in smoothies. And we don't know if down the road you could go down to 1 a day. The company says no. We don't have any data to show that that's the way to go. The deep sea marine protein supplement is again, weak evidence. However, the efficacy is good, and we had great results with our studies. I know that my teenage daughter went on this when she was young and had very thin hair and now has very thick hair, and she swears that that's what did it and tells all her friends and tells her teachers. Compliance is usually high, again, moderately affordable. This is amino marp C, so it's basically a product that is made from deep sea fish protein. So anyone that has allergies to shark or mollusks could not take it, and some other ingredients added to it. Just to show you some pictures on the left, again, this was from our menopausal study, and women, again, from day 0 to 180. And then on the other side, this is to just show it works not just on one skin type. As you can see on the left side, that was a skin type 4-5. And here's a skin type +5-6, African-American from Dr. Burgess. And you can see, again, this is just with topical, with oral supplements alone. And here's a patient using the deep sea fish protein. And this is, again, before and after. And this is just 3 months. And that's all they've had. And again, this was not in, I put this in here because the point is that you don't have to only have a female pattern hair loss to respond to these kind of supplements. And here's a deep sea fish protein to just show the difference after 6 months. Other supplements that are out there, there are many different ones out there. I talk with patients all the time who come in with their bottles. What I like to see is I like to see some data. I like to see research behind the name. I like to see that they've done clinical trials, standardized, placebo-controlled studies to know that they really work. Cyrano Repens has some weak evidence, moderate efficacy. Side effects were rare. Compliance was high. A saw palmetto-based product. There's some other ones that we are doing some studies on as well. And then, of course, oils. People ask all the time, and I say that we really don't have any. It's really weak evidence. It's anecdotal. I haven't seen any really great studies to show that any of these really do. But I have some patients that swear that their rosemary oil really helps their hair growth. Other new and upcoming treatments include the clascaterone, which, or clascaterone, I always say it wrong. Really TBD, we need to know how it works. It's not exactly like spironolactone, but it can mimic some of the effects. And so the question is, does it really do anything? And then the cetirizine, again, to be determined. I like mentioning the oral JAK inhibitors only because, again, yes, that's not necessary for an androgenic alopecia, but oral JAK inhibitors really have come a long way. And I think we need some clinical trials. Perhaps it would be more useful in a non-specific alopecia, and perhaps we would see some results, but we don't have any really great data for the female pattern hair loss. Exosomes are one of the new buzz. I love exosomes. I think they're really great. I think we need more data. We're conducting a trial right now on exosomes and hair loss. I think we just need the clinical trials out there to show that it really works. I think these extracellular vesicles, again, you're bringing these microRNA and messenger RNA and proteins to the area, and we really can regenerate hair. So I think they're an exciting new option. Just to show you a patient of mine, 1 session, 3 months after 1 session with exosomes. I mentioned in here, I just want to quickly say that, we want to know where exosomes are sourced. There are options available from umbilical cord stem cells to the adipose, bone marrow, plant-derived, and again, different options that are sourcing the exosomes, and then different versions of the exosomes that you can get, purified in bottles that are frozen, lyophilized in creams. You can get the exosomes out of the PRP, and of course, in plants. This is just to show you our trial that we are doing, that we are conducting with Benev on hair loss for hair loss. And always I throw in here the treatment option of hair transplant. Some patients really don't want to do all the options that we've discussed, and transplant may be an option. The efficacy is very excellent. Evidence is strong that it works. Just make sure you have the right patient, and if you're not sure, send them to a hair transplant for a consult. Side effects, of course, infection, scarring, pain, itch, swelling, and bleeding. I think you have to keep in mind when you talk about compliance, and I explain this to my patients, that maybe 1 time is enough, but most of the times they will need multiple sessions. And so it may not be an option as far as price goes, because it can be expensive. And understand that they may do all this, and then the hair transplant surgeon may say, oh, and we also want you to do lasers and take these topicals and take these supplements. So it may not be a one and done, but it depends on the stage of hair loss. It depends on the, where the pattern looks. And again, send it for a consult, because again, that is an option. They have newer devices now, ellipses and robotic follicular extractions are options. So what is my conclusion? Take your time with your patient. Really make sure that you're going through all the details that I talked about. Do handouts. I love handouts. I like them being able to take paper with them. They can then go over the different treatment options we have, and they may not choose that day to take anything home, but frequently someone will say, you know what, let me just read through all this, but while I'm here, I want to grab my supplements and I'll grab some topicals, something like that. Make sure they understand how it works. Do a workup if you're questioning anything else. Even with androgenic alopecia, make sure that you do a workup that they don't have any kind of thyroid disease, ferritin, vitamin D deficiency, anything like that. Reviewing the options, prices, time frame, frequency, understanding that this is an indefinite treatment. If you have androgenic alopecia, we're not going to fix it and then you get to stop everything. Combination does work best. There aren't a lot of combination studies. We need them, but they aren't out there. I discuss hair thinning with all my patients. So if someone comes in and even if they don't necessarily have thin hair, because people may come in and look like I do and say, oh, my hair was twice as thick. And I will tell you, for me, going through menopause right now, I'm going to be 59 and my hair is half as thick as it was as well. So something to address. Also talk about stress, nutrition, lifestyle, and your ethics in treating hair loss. So thank you for your time.
Thanks, Glynis. That was wonderful, as always. I mean, I think it's such a complicated thing, right? As far as why you get it, and then all the different treatments and trying to figure out. And I think what you said at the end, the combination is what you do. And I actually still do hair transplants in my office with the robotic thing. But if I do it on somebody, they're getting so many more things added on compared to the old days when I did nothing. So they're getting their nutraceuticals, they're getting their exosomes, they're getting everything as part of the post-care, right? And then they're on something, whether it's minoxidil or low-dose minoxidil or finasteride if it's a guy. And so I just think it's important that we all keep in mind, and hopefully the panel will share more stuff with us. So we're going to move on to our sponsored talk for this session. But before I do that, I want to encourage everybody that there is an audience poll out there. We encourage everybody to participate, where they want to figure the number of patients that we're seeing in our practices with hair loss and how this plays into what we're doing. So Dr. Vaibhav Kumar is going to speak for a few minutes. You have, my understanding, like 5 minutes, and he's gonna talk on QR 678.
A very good day to one and all. This is Dr. Vaibhav Kumar here from the QR678 team, and we are proud to be the educational partners of the HairTalks powered by Global Cosmetic Surgery. We thank Dr. Ablon for giving an insightful journey about the yin and yangs about female pattern hair loss. And we would be delving further upon our take upon the various facets of the same. So let's see the various deconstructions of what, when, and how to treat and manage female pattern alopecia. So we all know that the onset of the female pattern hair loss begins in the ripe reproductive years as early as 25 to 29 years. And it has a great impact affecting the psychological well-being, self-esteem, social functioning, leading to grave manifestations such as anxiety, depression, and overall reduced quality of life. The etiology of female pattern alopecia is complex indeed. There are various factors that are interlinked and intertwined, which act in singularity or in combination, where it could be the genetic predisposition, the hormonal imbalances such as PCOS, menopause, and postpartum, environmental factors such as stress, poor nutrition, and very interestingly, that in female pattern hair loss, there's an increased sensitivity of the hair follicles to even small elevations in the androgen levels. There are gamut of investigations that are there, complex, difficult to understand, various permutations and combinations, doing hormone profiles, USG of the pelvis, various vitamin tests, and so on and so forth. But it's extremely critical to understand the intersection between female pattern hair loss and polycystic ovarian syndrome. Now, we all know that the polycystic ovarian syndrome leads to an androgen excess, which can trigger or worsen FPHL. So much so that the meta-analysis showed that the FPHL affects around 28% of the women with PCOS. And the prognosis indicating the fact that in women with PCOS, FPHL may persist or progress if left untreated due to the chronic nature of hormonal imbalances. The QR678 Neo is a revolutionary biomimetic peptide-driven therapy for anti-hair loss and hair regrowth. It has 6 stimulatory, specific, and sustained biomimetic polypeptides which are responsible for the hair regrowth on the scalp. The insights from the QR678 Neo for the management of PCOS has been indeed fruitful, where 150,000 patients were treated for hair loss and hair-related concerns, out of which 30% were diagnosed with FPHL, and among these, a staggering 70% were at the age median of 18 to 36 years, whereas the remaining were postmenopausal. And of the women aged 18 to 36 years, 90% of those with FPHL were diagnosed with PCOS. And very interestingly, 28% of the women with this particular presentation discovered that they had PCOS only after seeking treatment for hair thinning or hair loss. Delving into the next part of the hidden link between FPHL and telogen effluvium. Now, we all know that telogen effluvium is a reactive process triggered by multiple factors, and it can accelerate in a very acute form the onset of female pattern hair loss in susceptible women. Very interestingly, the QR678 Neo contains biomimetic polypeptide, that is KGF, which plays a crucial role in enhancing the survival of the hair follicles in the cases of such cytotoxic insult. So how can the QR678 Neo treat female pattern hair loss? It has a targeted action where it directly stimulates hair follicles for better regrowth. It has non-hormonal interferences, making it safer for women with hormonal sensitivities. It has faster and quicker results in improvement of both quality as well as quantity of the hair. It has minimal side effects, being a non-invasive therapy. and it is clinically proven, backed by multiple published papers on the various facets of alopecia as well, causing significant improvement in female pattern hair loss. This is the published evidence of the QR678 Neo in the management of polycystic ovarian syndrome associated hair loss. And it was concluded in this prospective trial that the intradermal administration of the QR678 Neo is effective in managing such cases. One of the first case studies and a prospective clinical single-blind study that was published with the QR678 Neo in the management of post-COVID telogen effluvium, where around 90% of the patients showed excellent hair regrowth. So the QR678 has the spark to save the follicles. It has stimulatory growth factors. It protects from DHT and inflammation. It has anagen phase activation, rejuvenates the hair follicles, and it has key factors in stimulating the dormant follicles as well. These are some of the before and afters of cases managed by the QR678 neotherapy. So to conclude, female pattern hair loss is often associated with increased DHT levels in women. The QR678 Neo counteracts the effects of hormonal disruptions in the scalp, promoting hair follicle rejuvenation, and very importantly, addressing the underlying follicular dysfunction as well, acting from the root to tip in the entire hair-related architecture of the scalp. I thank you for a patient hearing.
All right. Thank you so much for doing that and presenting that. And I do want to make a comment because I think I've been following QR for a long time. It is an injectable. So in the United States, as we've talked before, we're not allowed to inject things into the scalp. If you can apply it topically, I assume here in the US, but if you're listening in the US, this is something that we cannot do. All right, so we're going to move on to our panel discussion. We have a great group of people here. I'll pronounce everybody's name wrong, so I'll apologize. So I'm going to use your first names. No, Dr. Sarah Lenzi, Dr. Aparna Santhamam, Dr. Ganeshram Sivaram, Dr. Rajit Kandahari, Dr. Parul Suji, and Dr. Mohan Shinoy. Dr. Pearl is a gynecologist. Dr. Mohan is an endocrinologist, which I think is really great to have in a panel discussion. And so I encourage everybody to pipe in, but I'm gonna change so the audience knows everybody was sent some questions before the webinar started. But I'd like to actually start with our non-dermatologists for a minute. So I'm going to put Dr. Mohan and Dr. Pearl on the spot first. So Dr. Mohan, how do fluctuations in hormones such as thyroid, insulin, cortisol contribute to female pattern hair loss? And I have a puppy barking in the back. And what role does hormonal therapy play in managing this condition? So Dr. Mohan, can you comment on that?
Yeah, thank you, sir.
And why don't you tell us where you're from and
yes, sir, yes, sir.
all that kind of stuff.
Thank you, sir. Am I audible?
All good.
Yes, you are.
Yeah, so just wanted to confirm. So as you know, I'm an endocrinologist. I am based in Trivandrum, Kerala. So I have been doing research and I am part of the Endocrine Society of India as an executive committee member, as well as the executive committee member of Indian Thyroid Society. So we do have patient awareness, patient advocacy, and we do drive in research through our journals and our research grants and all. So that is me, and we are doing some good articles on on PCOS or polycystic ovary syndrome. So most of our patients or clients, as we call nowadays, are aware of what these problems do happen. So without much ado, I will start off with the question which you have asked me. Hormones have a close relationship or association with hair growth. So they impact the hair cycle and hair follicle structure. And many hormones, as you had mentioned, like testosterone, insulin, growth hormone, and you have got cortisol, as well as thyroid hormone. These control the hair growth, the cycle, and density of hair. So hair abnormalities are quite frequent, and emotional discomfort, as our keynote speaker had definitely told us, so many stressors, they influence the society, and so many ethnic standards also are there. So endocrine system has got so many disorders by itself that impact the variety of physiological hair growth, and they alter the cycling of the hair. So as you know, hirsutism, pattern hair loss, they impact the human personality also. And as you have asked me the question regarding the insulin and the thyroid hormone as the cortisol, the fluctuations of these hormones occur throughout the hair cycle as well as the sleep. So thyroid, as you know, is produced from thyroid gland. So receptors are also detected on the outer root, the sheath cells within the hair follicles. So thyroid hormone is believed to responsible for regulating the frequency also have hair. Hypothyroidism causes decrease in the anagen frequency. That is, the anabolism is actually affected. And as you know that hyperthyroidism, the opposite of that, increased thyroid activity will cause the thin hair. So that both of them extremes can affect the hair cycle. And in fact, treatment of hair, the thyroid disorders can affect or improve this, but not to every extent. That is why we should remember the nutrition factors. Other factors should also be understood. In our place, even the water contains some chemicals, which is applicable to everywhere around the world. So that also has to be addressed. Then comes the cortisol. Hair fall is common in women and young people because of some stress and genetic factors. And cumulative stress cortisol effects, because these are definitely affecting the function and the regulation of the follicle. So high cortisol levels called hypercortisolism in Cushing syndromes. These cause decrease in the frequency of formation of hair follicle modulators like proteoglycans, hyaluronoglycans, essential for the follicle activity. Corticotropin releasing factor has a key importance in the stress hormone response. And if you have activating the CRF or cortisol releasing factor, these can actually be inhibiting the hair shaft elongation. And finally, insulin, as you know, it is important because they work in tandem with androgens. So hair development stimulation, hyperinsulinemia may boost the dihydrotestosterone synthesis by inducing the 5-alpha reductase activity. So besides these prolactin, melatonin, you can see growth hormones, so many hormones are there. So I think I can go on for many minutes or hours, but in a nutshell, I can say that endocrinologist is a key element in evaluating of hair fall disorders. And as you know, we work as a team. I don't treat the hair fall by myself. I refer to my derma or my cosmetic friend who definitely gives a team workup. And I finally let them also talk to the patient. And finally, we have a team collaboration. I hope your question is answered.
Yeah, that's great. I mean, I think we as dermatologists, I know I do a full laboratory profile. And then again, I think because I'm old now, if I see anything abnormal, it's like, okay, who's my endocrinologist today that I'm going to send to help me along with their primary docs? Because
That's
if
nice.
you don't handle those problems, I think you're not doing your job.
And we cannot do
again,
every test in every person, which will be individualized. That's also
Right.
one point. We cannot personalize precision care. We should as important test required and hair cycle. As we go on, we can discuss that also.
Right.
You know,
And again, for the please pipe in, like your Glynis, pipe in. Yeah.
I was going to say the only thing that because I love sending to my endocrinologist, I think that's huge. But I'm always very cautious. Again, like you just said, you need to know what you're treating. People are oftentimes coming to me with positive ANAs and they have no other symptoms. I'm like, well, why'd you run this test? And now you're running down this rabbit hole because you have a positive ANA, but everything else is negative. So be really specific. And if you're not sure, send to your endocrinologist. They will make the right testing choice. And that's the way to go as far as I'm concerned.
Yes, ma'am.
All right. So let's go on to our expert gynecologist here. So how do reproductive hormones such as estrogen and progesterone impact hair loss in women, particularly during menopause? And do you approach these differently? So Dr. Parrow.
Thank you, Dr. Michael, for asking that question to me. Yes, basically what happens is that estradiol can significantly alter the hair follicle and cycle to binding to the metabolism of locally expressed high affinity estrogen receptors. And progesterone also can influence hair growth through central and local action. So basically what happens is that these are the hormones which definitely reduce during the menopause. And there's a very nice article which basically quotes the menopausal transition is the hair follicle also going through menopause. So basically these estrogen and progesterone levels, they decrease, and estrogen, like we know, has a vasodilatory effect, meaning which helps to dilate blood vessels and improve blood flow. So with the decline in the estrogen levels during menopause, the blood vessels in the scalp may also constrict, and this would potentially result in, hair loss for these women. And also there is a lot of metabolic changes which occur because of decrease in estrogen and progesterone, which would be like, the glucose levels being high, and the reduce in insulin reduction in the insulin resistance. So all this basically would be, resulting in a drop at energy at all the levels of the body, especially the follicle also, the hair follicle also. And that would be resulting in hair loss in women, especially during that menopausal transition.
Great. Thank you so much. All right.
Can
So
I
now I'm
can I
gonna
add something?
go ahead. Yeah, go
So
ahead.
I oftentimes will show a graph for my patient, because as we go through menopause, it really is that, everything drops off very quickly. When you get there, that estrogen goes down, progesterone, but you do have that androgen excess for that long period of time. And that's where, again, addressing kind of where people are in their cycle, maybe considering, bioidenticals or hormone therapy, because if you can make that trend, that drop off not happen, a lot of patients do much better as well.
Can I also just add one more thing?
Mhm.
One of the things that I find practicing in India is that around menopausal time, we see a lot of coexistence of female pattern hair loss and chronic telogen effluvium coming at the same time. And therefore, checking the hormones and also checking the nutritional status by either sending to a gynecologist and also doing a full nutritional workup is really important, because sometimes both coexist and may require a joint approach to treat both the conditions.
Okay, great. All right. So I'm
Absolutely
gonna
right, Dr. Aparna. I just would want to add one thing, that when we have a lot of women in the menopausal and perimenopausal age group, just coming down to us, nutrition, especially in India, nutrition is the last thing which they would consider for themselves. In India, the Indian women, I think it's always about family, be it educated women, non-educated women. It's always that, they will be thinking about everything else but about themselves. And I think perimenopause and menopause is not considered something which it should be. That nutrition which totally takes the toll on you, not fulfilling all those things, is something which is very much responsible for hair loss in women, and a lot of other, nutritional deficiencies which pop in, because women in India do not actually take care of themselves, especially during menopause and perimenopause in totality.
The reality
Mohan,
is,
you want to say
if we really focused on nutrition, the drug companies would be out of business, because we wouldn't need a lot of these prescription drugs, because everyone would be so healthy. They wouldn't be taking all these things for their heart disease or that. I mean, it really is, it's scary how under discussed it is in every country, not just India. I mean, in every country. And part of it is just that we are, drug companies are pushing their drugs, and we're really not focusing on it. I mean, I teach nutrition course in the elementary school with my kids when they were little, and I mean, I loved it. And my kids will still go to a pharmacy and they'll look and see what exactly is on the prescription. And I mean, it's just, I think it's so important and started at a young age.
Mohan, you
Yeah.
want to say something?
Yeah,
Mohan?
thank you very much.
Yes, sir. Yes, I was just mentioning the extremes are also bad. Alopecia means you can anemia. Anemia is there, and even you have got overnutrition. You can see the extreme obesity. Those extremes also. We call malnutrition and malnutrition. So all these affect, because I think ladies nowadays, I think you can see average age of getting pregnant, that has also increased. That has also affected the cycles and all.
Sarah?
And also because of a
Yeah.
lot of
Okay.
treatments. There has
Totally.
been a lot of push in of progesterone and everything, which was a lot of hormonal interplay for these women.
Sarah, go ahead.
Thank you. Thank you very much for all the input. Thank you, Dr. Ablon, for amazing presentation. I want also to add something. Even the anti-androgen treatment for androgenic female pattern and androgenic alopecia, it works really effective if the ferritin level is above 40. So we can't, even in androgenic alopecia, just to treat the process of mineralization. So we have also to treat all the like vitamin D, and also the ferritin level is so important for the treatment to be successful. And as we know, the goal of treatment of androgenic alopecia is to reverse and stabilize the process of miniaturization. And the option is very limited. We just have like minoxidil as FDA approved. Other treatment are off-label. I believe in combination therapy, minoxidil, finasteride, PRP, and also I like low-level light therapy. I saw it's so practical and very effective. I've been using QR678 in my practice for chronic telogen effluvium, especially in adolescent. I like it a lot. And also
outside the US.
Outside the US, in Kuwait, in Bayan Derma, Kuwait. Yes, yeah, because it's injectable. In US, we can't do anything. We can do oxygen. We can just the PRP. So yeah, I find it's really good, especially for adolescent. And also, I combined it with PRP for female pattern alopecia. And yeah, I read all the studies regarding the QR678, and it's promising. Thank you.
Yeah. So I'm gonna go now. I'm gonna go to the two men on the panel. Then I'm gonna come back to the two dermatologists. So, question for the men out there: do you treat, or do you treat? How do you approach male pattern alopecia, or in the guys, and versus female? Is there something different than you do? So, Rajed, I'll start with you. I mean, again, we all see this every day, but we've just heard lots about the female world. Do you do something different if a guy comes in?
Thank you, Dr. Gold. So I think if, as already discussed, if it's a woman and a lot of these women have an FPHL and an overlapping, chronic telogen effluvium. So if you're seeing signs of hyperandrogenism, you're probably going to test them for certain hormones. And if you're not, you're anyways going to be testing them for certain deficiencies, which I find to be way more common in women as compared to men. So the iron levels may be required way more in women as compared to men, as well as the hormonal deficiencies. I mean, the hormonal disturbances obviously are way more in women than in men. In men, if at all, I'd maybe seeing the individual maybe do a serum insulin, a serum homocysteine, a fasting lipid at, as a part of metabolic syndrome. As for the treatment, I think from an approved sort of scenario, yes, you're going to be giving a 2% minoxidil in a female pattern hair loss versus maybe starting off with a 5%, of course, in a male. And in cases of the 5-alpha reductase inhibitors, I'd be much more comfortable maybe starting it in a male rather than a premenopausal woman, obviously. So I'd be much more comfortable in a postmenopausal woman starting those. Other therapies, I think, are fairly equivalent if you're doing in either in terms of the procedural interventions. Yeah.
All right. Thanks. And then in Kuala Lumpur, what do you do between the men and the women?
Thanks, Dr. Gold, for the question. Right. So I think the main difference between the men and the women is the more of the physiological trauma that they have to go through as well. Because for guys, it's okay to just go bald. But otherwise, for ladies, if they lose their hair, there's a lot of problem in the society and those kind of things. So what I usually do to treat female pattern hair loss is not much different from actually male. So usually I will do a proper examination first. And then after that, do the necessary blood workup, check the iron levels. Here in Malaysia, many women, they don't like to go in the sun. So vitamin D is like quite low for almost everyone. So definitely check the vitamin D, check the hormone panels. And then once I come up with a diagnosis, usually I would treat them. I'll put them on some oral supplements, definitely put them on some biotin. It's a building block for the hair. And then after that, depending on the iron levels low, they'll just replace them. And also, if it's a pattern hair loss, we're going to treat them with some DHT blockers. Here in Kuala Lumpur, we still use spironolactone. Sometimes also with finasteride. It could be topical as well. From the approved point of view, there's only minoxidil. So here in Malaysia, following the guidelines, we like to give it in oral form as well, because like for women, they're gonna put it in their hair, the hair is long and all this kind of things. It's gonna be a bit messy. So definitely oral is the way to go. And in my practice, I also tend to use exosomes. I definitely use QR. I use some, rarely do PRP now, but I see that which is different from other people, is that I also incorporate using a thulium laser, which fires right into the hair, stimulates the hair to grow, also creates micro channels. So in case they're putting something topically, it absorbs better. So that's my treatment plan actually,
Thank you.
usually for lady.
Yes. I mean, my world of hair is I don't do much of workup on guys anymore. I just don't. I mean, to me, unless there's a medical reason to do it, I don't do a lot of workup. But I agree with all of how you approach treatment. I'm actually studying a brand new non-ablative fractional laser, which I actually presented in India a few weeks ago. It's the first FDA cleared non-ablative fractional laser to try to grow hair. So Glynis, I have to tell you all about it. Sarah, I have to tell you all about it. But it's I don't do much of a workup. I do a big workup in females. All right, I'm going to move on to the two women experts here.
Sir, may I just add a point here, sir?
May I also
Sure,
just
please add a point.
Yeah, just want to add, because he mentioned about, doctor mentioned about biotin. Biotin is used over the counter in India, I think everywhere also. And high dose biotin can interfere with the thyroid function assay. So some people come with a thyroid abnormality, they think it is affected. It looks like hyperthyroidism like picture. The TSH can be suppressed and T3, T4 may be a bit low or normal. So we get a picture like a thyroid dysfunction. But actually, after stopping the high dose, maybe reducing for 3 days, maybe stopping it, it actually comes back. So that is a studying point.
Isn't the evidence for biotin, I'm looking to Glynis and Sarah here, the evidence for biotin is pretty low.
It really is. And I think that, and again, that's where that whole history is critical. You want to find out exactly what they're taking, what dose, everything, because you're correct. I mean, when I started my residency in 1993, I'm dating myself, I was told biotin and zinc for hair loss. And so I gave everyone biotin and zinc. I didn't know any better. And so we do know that it can affect different kinds of lab values. So I always tell my patients, if they're going to get testing, they do need to stop it a month before. But I do think that it's critical, what they're on. And you're right, we don't have data that shows it really does anything. It doesn't mean that a low dose will hurt you, but that high doses are not going to grow hair.
Because most of our patients, females, come to us, they're on biotin. All right, Sarah, anything you want to add?
No, just regarding the pattern between male and female pattern hair loss. I usually focus on the stage, like stage of hair loss. Sinclair, Ledwig for women, and also Hamilton for men. I like to use minoxidil, especially oral for men. It's work really good in the crown. And as you know, the side effect is hypertrichosis. So the men love it, especially in the beard and also in hair in the body, but women, they don't like the side effect. But if I have like a Ledwig stage 2 or 3, I have to start a low dose of minoxidil. For women, I start with 0.6 milligram up to 2.5. I find it's really good as also anti-inflammatory, not just a vasodilator. I add also a fractional laser. We use it in University of Miami. Fractional laser work really good. And there are many clinical trials regarding the fractional laser as delivery, drug delivery, and also stimulate the hair follicle. I like to apply it after the laser treatment. I apply topical corticosteroid or minoxidil, especially post-COVID hair loss. It worked really good, the fractional laser therapy.
All right, great. All right, so let me move on to the next, but we got a few more questions we want to get through. So for the two lady experts, and this is pretty, to me, straightforward. At what stage of hair loss would you start treatment in females, right? When do you think it's appropriate to start female pattern alopecia with therapy? So, Aparna, you want to start first?
Yeah, sure, Dr. Gold. Thank you. I usually start treatment pretty early. So once, especially in India, because there are a lot of non-dermatologists treating hair loss as well. So by the time a patient comes to a dermatologist, it's already well established clinically that female pattern hair loss needs treatment. So I like to start treatment quite early. The only difference is, we see a lot of female pattern hair loss even in the earlier age groups, like between 20 and 40, and of course perimenopausally and after 60. So when a younger patient comes in, I generally tend to, do a very detailed history taking also about motivation to stay on treatment, because these are long-term treatments. You start having female pattern hair loss in your 20s, you're actually looking at treating it for the next 2 decades. So understanding their motivation, whether they have the staying capacity to stay on something topical and oral, whether they want to go in for something interventional. But at all stages, I tend to start treatment quite early. And usually it's a combination therapy, like I think everyone else has spoken, including our guest speaker. So it starts off with a topical and oral medication and usually moves on to we do a combination of PRP with QR678, which we've been using for a few years now with very good results. And also sometimes we combine it with hair threads, the PDO threads, which we start off with the threads and then follow up with the PRP and QR678. What I find is that in the perimenopausal, postmenopausal age group, the workup is fairly important, and therefore we would not start interventional till the workup comes in and we talk to them in detail about nutrition, because India as a whole is a very protein deficient country. So along with doing the treatments, I think also giving them a very close nutritional outlook. And I know I'm belaboring the point and repeating it, but there are huge deficiencies, especially in protein across the country, so we tend to supplement that as well.
Sarah, when do you start? You're on mute. Get off mute. You're on mute, Sarah. Sarah, unmute yourself.
Okay.
There you go.
Okay. Hi. Yeah. Androgenic alopecia is ongoing and progressive follicular mineralization process. So I start as early, like even I told you, an adolescent. I have many cases of female pattern and also male pattern hair loss in women. I believe because our food, lifestyle, it's affecting our hormone. I saw many male pattern hair loss in women. So I start early, as I told you, with a foam minoxidil, something like very simple foam minoxidil or serum, but I prefer the foam because it doesn't contain propylene glycol, and some people get irritated after applying the serum. So I always encourage my patients to use the foam, 5%. I also do PRP every month. And when it is like advanced, I like to add dutasteride as a mesotherapy, and also oxazome. I use autologous oxazome, and also oxazome from adipose tissue. It's allergenic. I like to combine two types of oxazome, the autologous and the allergenic, and I find it's work really good, especially in male and female advanced pattern hair loss. As I told you, it's ongoing process. We can't like restore the hair from the beginning, but at least we will stabilize the disease. So yeah.
I think the key points for me is that I always tell my patients, this is a marathon. You're not going to have a full head of hair in tomorrow.
Yeah.
And if they don't understand that, it's sort of, I've got to sit there and explain it to them. And it's a process. And I tell, when do I start? I start when it bothers them. Right. Again, and I'm sure you'd all agree, the females come in a lot earlier in most cases than the men, right? They're bothered by it more than the men are bothered. So I start when it bothers them, it bothers me. That's what I tell them.
May I just
and
add
again,
something?
sure, Rajit, go ahead.
So I think the threshold of giving treatment for, female pattern or male pattern has gone down. I think, as Dr. Sarah said, that we'd have adolescents now coming in. So clearly something's changed. The genetic predisposition is being expressed. The gene is being expressed way earlier, whether it's the environment or the nutrition or whatever it might be. So we are treating them much earlier, but I think if it's a very young individual, I sometimes refrain from certain therapies, maybe start on a peptide and then move on to the minoxidil a bit later, because as Dr. Parna said, it's an ongoing process. You're going to be treating these individuals for decades. And secondly, I think we're seeing diffuse unpatterned alopecia in some of the younger adults also way more as compared to earlier. And it's very frustrating for them as well as for us, because the treatment is tough there and they don't tend to improve so easily as well.
Thanks. All right, so I'm gonna switch to another topic which we've covered a little, but I really want to get everybody's take on it. So obviously, the world of regenerative medicine has become humongous and across the globe. And I think what Glenn has shared with us is the evidence with PRP is high. I think we can actually say the evidence with QR is high, except we don't have experience here with it yet, but the evidence is high. And exosomes and things like that we're learning about, and the evidence is not that high right now, but we think it's going to be high. So I would love to get everybody's take. Do you use them, your experience and so forth? Are you going to go first to PRP and then to something else, or how do you approach this whole world of regenerative medicine? So I'm going to pick on Sivaram first. I know you mentioned it a little bit, but let's keep this to a minute or two each, because we're almost at time. But I would love to hear your thoughts on QR and PRP and exosomes, everybody's opinion.
Okay, right. So, the world of regenerative medicine is is like improving like very fast. So, from the point of PRP, like it went to PRF, and now we have like growth factor concentrates and also like mesenchymal stem cell injections even for the hair. So, what I believe in is like providing the best for our patients. So right now, many patients that come to me, they don't really request for PRP. They are looking for something extra. So that's when like QR comes in the picture, like exosome comes in the picture, those products which can take the extra mile for the patient to give them the results faster and also help them to get a much better result. So from the hair growth point of view, I've seen much better results even using QR like 1 to 2 times compared to using PRP 6 times in my previous practice. So the benefit is really high, and also the cost is about the same. So from that point of view,
Thank you. Mohan, do you do any of this the PRP world? I don't know.
Sadly, no, sir. I've already given my disclaimer. I don't practice in this tricky, muddy area.
I just wanted to.
Definitely.
I wanted to double check.
I would like to learn from what is experienced, but just want to add regarding the low calorie diet, lessening the glycemic diet. So that is also one way. I think those people who reduce the weight, maybe that also can affect the glucose and cholesterol metabolism, and this female pattern hair loss somewhat a bit. And when you use all these things together, that is definitely workable.
Dr. Parel, your thoughts?
Yeah, actually, I myself do not do a lot of hair treatments, being a gynecologist, but yes, for PCO patients, I started using QR678, and my husband happens to be a plastic, and my father-in-law also happens to be a plastic surgeon. So yes, we are using PRP and exosomes for our patients, and they're giving pretty good results. And we are using QR678 also for all these patients. And I think it depends on how much the patient is affordable and how much the ease it is, and how we convince them that whether they want to switch on to which kind of therapy. That's my take about any of these modalities which we are using for hair loss in females especially.
All right, Rajat, you're next.
I use it, and I'm using it in my practice. My journey
started
QR and PRP. Exosomes, I think, we're a bit new in India. But QR and PRP, yes, my journey started with combining it with PRP because I was, speculating initially. But I think what both give great outcomes. QR has done well in my practice. The biggest advantages for me have been easy to use. And secondly, it's almost painless. So, I don't even need to put topical anesthetic. It's like a 10-minute process. But I think some predictive factors we need to work on, that who's a good candidate and who's not. And I think that will come with time when we keep putting it into practice.
Great, thank you. All right, Aparna, then we're going to go to Sarah, and then we're going to end with Glynis, okay?
Sure. We do a lot of PRP and QR678. And like Dr. Rajat mentioned, we do combination therapies as well, sometimes on the same day, and we get very good results. I think what we are also trying to do is exactly what Dr. Rajat said, to get some predictive factors. Right now, the selection of the choice of selection of patient is fairly universal. Almost everyone who comes with FPHL, especially if they are affording patients and willing to do something interventional, we tend to do a combination. We also use PDO threads, especially preceding the PRP and the QR678, and we find that the combination gives us very good results. And exosomes, we're still in the trial phase. We've been trying both the salmon and the plant exosomes, still not launched it into practice, but we're hoping to have some definitive results in going. But definitely PRP and QR678, we've had very, very good results.
All right, Sarah.
Okay, as I told you, I've been using the PRP and the QR678, especially for polycystic ovary syndrome. It worked really well. And also early female pattern alopecia, also it worked really well. But I have some patients, especially because I treat scarring and non-scarring alopecia. Some of my patients, they are on corticosteroid or they are taking like NSAIDs. So I can do like PRP for them because it's contraindication. So I use oxazome for this group of patients who are contraindication for PRP. If they are anemic, hemoglobin less than 10, or if they are on corticosteroid, and also if they are bodybuilder who take like external testosterone. I don't like to do the PRP. I like to do a QR678 and also combined it with oxazome. I like oxazome. I believe in oxazome. And as I told you, like the allogenic and also autologous.
Great, thank you. All right, we started our talk with Glynis, and I want to end with Glynis. So just the world of regenerative medicine, which I know you and I are intimately involved here in the US as far as research and trying to figure it all out. What are your closing thoughts? And you're on mute, so come on, mute.
So I think that regenerative medicine is just kind of our next level. And that's where, again, we want to provide the best care for our patients. We want to know what's out there. Novel technology may or may not work, and that's where the critical. And I love that everyone is under this nutrition aspect of it. And so I think that, be honest with your patients, talk about hair loss with all of your patients. You'd be shocked at how many people are experiencing hair loss and are not even addressing it with you. And let them know we have novel treatments that are on the horizon and many treatments that are available today that really do work.
Great. All right. We are at our stop time, and I can't thank everybody enough. First, Global Cosmetic Surgery for putting this on, for QR for sponsoring it, and then this amazing group of panelists from all over. I can't thank Dr. Ablon enough for waking up really early. She'll need an afternoon siesta today. And I just want to thank everybody. And we will have another Hair Talk session in about a month. I think it's going to be in about 3-4 weeks. We will get you all the information on the topics and speakers and panelists. But I wish everybody a great morning, a great afternoon, a great evening. And again, thank you so much for being part of this. And Debraj and Tanuj, thank you for letting me host. And we'll see everybody next time. Take care, everyone.
Thank you.
Thank you. Thank you so much, Dr. Gold. And thank you all.
Thank you very much for having me.
Thank you, everyone.
Okay, I think are we off now?
We can leave the meeting.